The next important aspect is surfactant therapy. So you can review the video I posted recently on the pragmatic approach to RDS management, and that covers most of these parts. I mean, even though it was before the guideline came up, most of it would agree with what is mentioned in the guideline. If a premature baby less than 30 weeks gestation requires intubation for stabilization, they should be given surfactant. So that is well agreed. These babies have already been intubated and very high risk of RDS. So the earlier you give surfactant, the better. So you can give surfactant to these babies. And babies with RDS needing treatment should be given animal-derived surfactant preparation. At the moment, we don't have a synthetic surfactant which is marketed with appropriate evidence, even though we are likely to get something in the pipeline soon. Leucinactant has been withdrawn from the market, so we have to wait for the next product. LISA is the preferred method of surfactant administration. So this is based on recent evidence. Again, I have just published another video looking at the non-invasive ways of surfactant administration, and either LISA or INSURE can be used according to what your unit practices. The guideline is suggesting LISA as a preferred method. Laryngeal mass surfactant may be used for more mature infants more than 1 kilo. So again, I've discussed that in the other video. I'll refer you to that. So don't be fixated on which non-invasive way. The main aspect which is going to damage the lung for risk of BPD is prolonged ventilation. So as long as you're not intubating and keeping the baby intubated for a long time, you can use whatever suits you best. I have used INSURE mainly in our unit, and it works quite well. In practice, the BPD rates are lower than what is reported elsewhere. For poractant alpha, we all use a 200 milligram per kilo higher dose, initial dose, because it has shown a reduced need for further surfactant as well as improved survival. For biractant, you use 100 milligram per kilogram. If you are using a second dose, you go to 100 per kilo for poractant as well. The rescue surfactant should be given early in the course of the disease. So some of you had discussed the need for IPPV, NIPPV versus CPAP in the initial stage. So we restrict to CPAP of pressure 6 to 8 centimeter of water, or FiO2 up to 30. And if the baby doesn't cope with it, it's better to give surfactant to these babies, as it's likely RDS, and you don't want to use a high pressure on a lung which has significant RDS. A higher risk of air leak will ensure, and the higher pressure used may not be good for the baby's tummy. A higher risk of SIP possibly is there. So if the lung ultrasound suggests, you can decide on the surfactant. And please, as I've discussed in the video on the pragmatic approach, remember that all of these, the FiO2, RDS risk, and the findings on X-ray are variable. It's an evolving disease, so you need to be careful about it. A second and occasional third dose of surfactant should be given if there is ongoing evidence of RDS, like persistent high oxygen requirement, after other problems have been excluded. So most of the time we don't need more than 2 doses. I have not needed a third dose recently, and even the second dose is very infrequently needed these days. If you have used less invasive surfactant for the first dose, you can use it for the second dose if the baby is coping otherwise. There are some indications where you want to keep the baby intubated if the CO2 is very high, if the baby's work of breathing is very significantly abnormal, or there is a risk of PPHN or infection. You can have a lower threshold to keep the tube in for a few hours to decide on the subsequent course to avoid repeated intubation efforts. So this is a summary of what we have for surfactant therapy. In terms of oxygen supplementation after the stabilization, in the premature babies who receive oxygen, the saturation target should be between 90 and 94%. This is the evidence based on the support and the boost 2 studies, and it is well established now. The alarm limits, of course, you may decide individualize it on the baby, but the recommendation is 89 to 95%. This is always a debate as to what your upper limit setting should be to avoid over intervention, and obviously the nursing time, the effort is considered as well. So you can go up to 96 or even 97% in the babies who are very sensitive to slight adjustments in FiO2. For example, you have less than 25% oxygen, and if you keep 24%, the baby desaturates, and if you keep 25, baby goes to 97. It's finely tuned, so in these cases you can individualize and keep the setting about 96 to 97% as upper limit. The same applies to the lower limit for a baby who is labile and keeps dropping. you can consider 87 or 88 for a brief time. So these are individualized decisions and you should document it in your plan. And if you educate your nursing team, they themselves will become aware of what settings they need to do this. But definitely increasing the FiO2 delivery will affect ROP risk, and so we have to be very cautious, especially in the extreme small babies who are at the highest risk of ROP. And protocols for screening and treating premature babies for ROP should be in place as well. So this is very important, and all of you may be familiar with the ROP guidelines in the developing countries having a little aggressive approach compared to the ROP guidelines in the developed world. That is because of the aggressive posterior ROP development in some of these IUGR or nutritional deprived babies. Again, it's very important to discuss the role of closed loop oxygen monitoring. There are studies coming out that these are beneficial, but we need the exact ideal algorithm which avoids the oxygen requirement going too high. And again, one of the disadvantages possibly is that you may delay picking up a baby who is deteriorating because otherwise the nurses might have alerted the team earlier. So we have to see the range which is acceptable, and the algorithms have to be fine-tuned to that. In terms of non-invasive ventilation, we have CPAP or NIPPV started at birth in all babies at risk of RDS. So here I would slightly differ that NIPPV at birth we can delay till you make the decision on surfactant use. So as I mentioned in the other video on pragmatic approach, I'll link it with this video as well. So if you start NIPPV, you may start giving higher pressures in a baby with RDS without the surfactant from which they would benefit. Of course, if you are in a resource limited setting and you are monitoring closely, you can use NIPPV, but if you are in a developed country and you are not limited by resource limitation, better to start with CPAP of 6 to 7, and if oxygen requirement is rising or if the work of breathing is increasing and you think baby needs NIPPV, better to give surfactant by LISA or INSURE before you go to NIPPV. So babies less than 30 weeks gestation who do not need intubation for stabilization, you start with this. Non-invasive ventilation with early surfactant by LISA is considered optimal management. So this is a big shift over the past 10 years or so. There is no role for prophylactic surfactant, but early rescue by LISA is suggested. The system delivering CPAP is of little importance, so bubble CPAP, infant flow driver, ventilator CPAP, they all work similar. Slight differences will be there. You have to use what works best for your setup. The interface should ideally be a short binasal prong or mask with a starting pressure of 6 to 8 centimeter of water. Ability to escalate NIPPV will reduce the need for invasive mechanical ventilation in some infants. So obviously they're acknowledging that NIPPV is better than CPAP alone, and that's the experience most of us feel. There are discussions about the interface for NIPPV, whether RAM cannula can be used. We have used RAM cannula, but you do need to increase the pressures to offset the resistance that the circuit provides. And usually we see that RAM cannula NIPPV is a little less effective compared to NIPPV with the ventilator provided interface, but it is still better than CPAP. So you have to titrate and use according to what is available to you. BiPAP devices confer no advantage over CPAP alone. So this is again biphasic CPAP using the VIAS device. The infant flow driver works a little better. You can recruit more, but the effectiveness is not going to change much. Synchronized NIPPV, if delivered through ventilator, can reduce the need for ventilation or need for reventilation following extubation, and it may also reduce BPD. We also acknowledge the role of high flow nasal cannula as an alternative to CPAP. In the text, the authors say if the unit has enough expertise, you may be avoiding the use of CPAP or NIPPV, but again, it does appear clinically a little inferior to NIPPV or a higher level of CPAP. So if the baby is in the evolving phase of RDS, it's better to go for CPAP or NIPPV and then step down to high flow once we know they're stable. High flow works on babies who are stable on 5 centimeter CPAP or below. It's based on what we have experienced. Again, the point about how long to keep the high flow, don't be in a rush to wean the smallest babies off the high flow or CPAP. When they are evolving with the feed progress, the reflux and the intermittent hypoxemic episodes will be reduced if you have an option to recruit the lung volume or support the babies from de-recruiting quickly. So keep a pressure of 3 to 4 centimeter 3 to 4 liters flow with high flow or 4 centimeter CPAP. For babies under 32 weeks or under 1.25 kilos, still they cross this threshold. When they're free of intermittent hypoxemic episodes, then you take them off, then you are likely to stabilize them better. In terms of mechanical ventilation, so mechanical ventilation is limited to babies with RDS where other measures have failed, and duration should be minimized, so you try to extubate at the earliest. There is no doubt that lung protective strategies like volume targeted ventilation, volume guarantee, or high frequency should be the first choice. I'm not sure why they put high frequency as the first option when majority of the units don't use high frequency as the first option. Most of us keep high frequency as a rescue, but with more advancements in high frequency, the ability to use at higher frequencies like 12 to 15 hertz and volume targeted high frequency, if you have these facilities, you might start using that as a preferred mode. One of the issues with high frequency is obviously the need for sedation, which it doesn't look right not to sedate these babies, while in conventional ventilation and volume targeted modes we get away without any sedation. So we still would vote for volume targeted rather than high frequency, but if the baby has worsening, you can have a low threshold to switch to the newer high frequency modalities, especially with volume guarantee. When you're weaning from mechanical ventilation, it's reasonable to tolerate a modest hypercarbia. The threshold to which you accept permissive hypercapnia, especially in the first week to 10 days in the extreme premature babies, should reduce. So anything above 55 to 60 centimeters should be an alarm bell, and ideally keep the PCO2 below 50 to 55 where possible. Obviously avoid hypocarbia as well because it has a high risk of PVL. So as long as the pH is maintained above 7.22, you can accept 50 to 55 PCO2. Beyond the first 2 weeks, you can start accepting more hypercarbia. Hypercarbia has effect on the cerebral perfusion. The risk of IVH is more, and also increased risk of NEC has been shown with hypercarbia as well. BPD risk is more with hypercarbia, strangely. So we can't predict all the responses, so we have to be careful. Nitric oxide in the premature babies is used fairly frequently, but we should be limiting it to a therapeutic trial for those babies where there is documented pulmonary hypertension with severe RDS, especially where there is a setting of PPROM or low amniotic fluid volume. So if you have this setting, you can use the nitric oxide earlier before you go for very high pressure requirements and damage the lung due to that. So you can give a trial in these babies. Of course, as a desperate measure in the babies who are not coping, obviously it has not been really beneficial. Even if you use it, it doesn't make any difference. I'm talking of the 23 or 24 weekers where you're not able to oxygenate them just because of the immaturity. In these cases, nitric oxide doesn't help. Caffeine at a dose of 20 milligram loading and 5 to 10 milligram maintenance should be used to facilitate weaning from mechanical ventilation. Early caffeine can be considered for babies at high risk of needing mechanical ventilation, such as preterm babies on NIV. So this goes without saying that if the baby is on NIV, you'd give the caffeine immediately after birth. And even if the baby continues to be ventilated, we tend to keep them on the caffeine, especially after the result of the CAP study. But if a baby is intubated from the beginning, whether you start caffeine early or you wait when the baby is close to be extubated is still debatable. You can review my video on apnea of prematurity and the role of caffeine. There is no clear answer, so caffeine should not be taken as a drug totally safe as well. So use it with caution and don't exceed the recommended doses unless you have a clear reason to. An additional loading dose of 10 milligram per kilogram can be given, or an intermittent top-up dose can be given, but to go more than 10 milligram maintenance is probably not advisable. As the babies grow older, you may have to increase the dose of caffeine due to the pharmacodynamics changing. A short tapering course of low-dose dexamethasone, what we call the DART regime, can be considered to facilitate extubation in babies who remain on mechanical ventilation after 1 to 2 weeks. So whether you use it at 1 week or 2 weeks depends on the gestation of the baby. The smaller babies, you can wait longer. The relatively more mature, like 27, 28 weeks, if they're still ventilated by 1 week, because you would expect majority of them would be off ventilation by that time, you can use by 1 week. The babies below 26 or 26 and below, you can consider at 2 weeks. Opioid should be used selectively when intubated by clinical judgment and evaluation of pain indicators. Routine use of morphine or midazolam in ventilated preterm is not recommended. I fully support this as well, and sedation should not be taken lightly. We don't know about the long-term impact on the developing brain. Midazolam causes significant fluid shifting. You get a lot of edema-related problems, fluid balance, renal function-related problems. So use it for minimal periods only if it is essential. In terms of monitoring and supportive care, the core temperature should be maintained 36.5 to 37.5. I will request you to review my playlist on thermoregulation where many of these aspects are covered. IV fluid 70 to 80 ml per kilo in a humidified incubator with close regulation. Again, I have a lecture on fluid management in the small babies, including feeding. I'll refer you to that. Parenteral nutrition should be started from birth. There is no doubt that adequate nutrition from the beginning is very important. Amino acids, we start actually with 3 grams from day one. Lipids start with 1 to 2 grams and increase quickly. We don't usually exceed 3 grams to 3.5 grams of lipids, but maximum 4 can be used if there is growth issues. Amino acid, we go up to 4 grams in most of the small babies. Enteral feeding with mother's milk should be started from the first day if the baby is hemodynamically stable, and that would mean if the baby doesn't need inotropes or is not hypotensive. So trophic feeds early on is best, and as soon as the baby is stable you can start progressing at the appropriate rate. Again, the video I mentioned on feeding and fluid balance covers all these. In infants with the RDS, the antibiotics should be used judiciously and stopped early when sepsis is ruled out. If you are going through this and you have any concerns finding the videos that I am talking about, you can just comment and I can share the link immediately. In terms of cardiovascular support, treatment of hypotension is recommended when there is evidence of poor tissue perfusion such as oliguria, acidosis and poor capillary refill. So the reason they are mentioning this is the concept of not going by the exact numbers. Of course, functional echo, if you are able to do it by the bedside, it would guide you on how to approach it. And in terms of PDA treatment, again, you can refer my video on PDA treatment, a pragmatic approach as well. So paracetamol, they suggest when there is thrombocytopenia or concerns about renal function. And actually, I support the Iowa approach where paracetamol is the first line in the small babies. Invariably, there is a concern about renal function in all the tiny babies, and paracetamol has been shown to be reasonably safe. As I mentioned earlier in the comment on steroids, the long-term neurodevelopmental effect is probably a temporal and an association than an effect. So you don't need to be worried about it at this stage. So we will be waiting for further evidence, and unfortunately the Benedictus trial and the other studies did not give any clear verdict on ibuprofen. So the Iowa approach, there is evidence coming out as well from a first study as well that the exposure to the shunt is important. By reducing it, you may be helping these babies. So in the tiniest babies, treat the PDA early, start with paracetamol, and if paracetamol doesn't work after the first week to 10 days, you can go for ibuprofen. In the bigger babies, you can consider a higher dose of ibuprofen as well. The thresholds for red blood cell transfusion is set at 12 grams for those with severe cardiorespiratory disease, 11 grams for those who are oxygen dependent. For stable babies, they have put a cutoff of 7 grams at beyond 2 weeks. I don't agree with it. It depends on the gestation of the baby. In the tiniest babies where they are well off the mark of producing their own red cells, which you would expect by 6 to 8 weeks when the nadir is persisting, these babies are far off. So in the smallest babies, you would probably use a threshold of 8 to 9 grams if they are off oxygen in the first 3 to 4 weeks of age. And remember the evidence that the lower the hemoglobin goes, there is a possible risk to the brain as well as the increased risk of NEC. Transfusion associated NEC may be related to the lower level of anemia that we accept. So in babies at highest risk, so I don't know how this got passed as beyond 2 weeks you put it at 7 grams. So again, the purview of this guideline doesn't need to include points like this which are controversial. So again, I would caution about this point. Surfactant can be used for RDS complicated by congenital pneumonia. Again, surfactant can be used to improve oxygenation following pulmonary hemorrhage, and surfactant can improve oxygenation with severe meconium aspiration. So there is no real change in these guidelines. So that's the last slide, and obviously like in any guideline, a guideline has to support your management. There are reasons for modifying the guideline locally, and as I said, thresholds like this which you have to be cautious about. Maybe for a baby above 4 to 6 weeks or a bigger premature baby, you can apply this. So don't assume that just because it's in a guideline everything is suitable for your use. You have to look at the evidence from your own perspective. The guideline obviously supports you, but you have to be cautious in how you use a guideline. And the point I made in the beginning about market sponsoring again is something to consider in a guideline which is widely used in the neonatal circle. So thank you for watching, and do share. Thank you.